So good morning, everyone. My name is Debbie Chen, and I'm an endocrinologist and researcher at the University of Michigan who focuses on thyroid cancer. So I would like to thank the organizers of the conference for inviting me to present on this important topic on racial disparities in thyroid cancer care. So I have no disclosures. So this is a quote that resonates with me and motivates me to work to address disparities in thyroid cancer in my own research. At a convention of the Medical Committee for Human Rights held in March of 1966, Dr. Martin Luther King Jr. declared that of all the forms of inequality, injustice in healthcare is one of the most shocking and inhumane. So healthcare disparities is important in its own right, but also because of its reflection of the unequal distribution of power and resources based on race and gender in our society. So over the last 2 decades, at least, the estimated number of new cases of thyroid cancer in the United States has increased significantly. In 2020, there is an estimated 52,890 new cases of thyroid cancer in the United States. Among Hispanic women, the numbers are even more staggering. So based on cancer data from the American Cancer Society, thyroid cancer was the second most common cancer among Hispanic women in the United States, with an estimated 6,800 new cases of thyroid cancer in 2018. A review of the thyroid cancer literature shows that racial and ethnic minorities with thyroid cancer are more likely to receive suboptimal care compared to their white counterparts. For example, patients from racial and ethnic minorities were more likely to be diagnosed with more advanced disease, have thyroid cancer surgery performed by lower volume surgeons, and report more worry related to their thyroid cancer. So as you can see, the disparities are seen in many different aspects and time points in the treatment of thyroid cancer. But before we delve into the studies on patients with thyroid cancer, I think that it's important to understand the context in which these racial disparities occur, especially the cost of the healthcare in the United States and the significance of social determinants of health. So since there are many different topics that we're going to touch upon in this talk, I thought it would be helpful to have a roadmap for how I have organized this talk to give you some direction. So first, I'll define how race and ethnicity is used in many of these studies, then briefly discuss the cost of our healthcare system and health disparities in general. Then I will discuss the impact of social determinants of health, which is important in understanding the racial disparities that exist in thyroid cancer care, when I return to the data that I've just provided you a glimpse of. I will then identify the factors that contribute to such disparities and then spend some time on the potential strategies for improvement to wrap up this talk. So simplistically, race is often used to define someone by their skin color as well as some other physical, social, and biological attributes, whereas ethnicity often refers to the way in which someone identifies learned aspects of themselves, such as nationality, language, and culture. On this slide, I include the definition of race provided by the US Census Bureau, which states that the race categories reflect a social definition of race recognized in this country and not an attempt to define race biologically, anthropologically, or genetically. In addition, it is recognized that the categories of the race item include social and national origin or sociocultural groups. On the right side of the slide are the categories for classifying race and ethnicity recommended by the US Office of Management and Budget, which has been adopted by many federal agencies, including the National Institutes of Health and the US Census Bureau. White refers to a person with European, Middle Eastern, or North African ancestry, and Black or African American refers to a person having origins in any of the Black racial groups of Africa. And although it does not adequately address the complexity of race and ethnicity in America, these categories do provide us with a common language to use in research studies. And interestingly, the 2020 census permits for the collection of more granular data regarding race. Notably, the race categories for Asian has been expanded to include culturally distinct ethnic subgroups, such as Chinese, Filipino, and Japanese. And the race categories for Pacific Islander has been expanded to include origins from Samoa and Guam. To provide some context for the racial disparities in thyroid cancer, I would like to briefly discuss the status of the US healthcare system, which is one of the most expensive in the world. This figure shows the average amount of money that select countries spent on healthcare per person in 2018. And as you can see, the United States is at the top with an average per capita health expenditure of $10,586, which is more than double that of our neighbor Canada and more than triple that of Italy and Spain. This is another graph illustrating healthcare spending in the United States relative to select other countries. The x-axis is years from 1970 to 2015, and the y-axis is per capita expenditure. And as you can see, from 1970 to 2015, the per capita expenditure in the United States more than quadrupled over this time period. And this increase is greater than that observed in other Western countries, such as Germany, Italy, and the United Kingdom. So this figure illustrates the relationship between the average health expenditure per person in the United States and the average life expectancy in that corresponding year. So the x-axis is the average health expenditure per person and ranges from $1,000 to $8,000. The y-axis is the life expectancy in years and ranges from 68 to 82 years old. And then each data point on the graph represents that for life expectancy and per capita health expenditure in a particular year in the United States. And then the data points are connected by the red line to illustrate the trend in changes of these two values over time. And so we look at the leftmost data point for 1970 in the United States. We see that the per capita health expenditure was about $1,500 and life expectancy was about 71 years old at that time. And then if we look at the rightmost data point for 2008, we see that the per capita health expenditure increased to about $7,600 and the life expectancy increased to about 78 years. And so initially this data seems pretty good. Although we're spending more on healthcare over this 38-year period, at least we're seeing a corresponding increase in life expectancy. However, when we look at the data for another country, such as that for Germany, for example, the initial excitement falls pretty flat. In this figure, the numbers for the US is shown in red and the numbers for Germany is shown in blue. So in 1970, the per capita health expenditure in Germany was about $1,200 and the life expectancy was about 71 years old, which is pretty similar to that of the US. And you can see that the lines overlap a bit. However, over the next 4 decades, the per capita health expenditure in Germany only increased to about $4,000, while the life expectancy increased to about 80 years old. So in the same time period, Germany spent less on healthcare and people live longer than those in the United States. So if we look at life expectancy data in the United States in more depth, it becomes obvious that despite an overall increase in life expectancy over time, there are differences based on race and sex. So this figure illustrates the life expectancy in the US from 1970 to 2017, broken up by race and sex. The x-axis is years and the y-axis is age in years. And the different color lines represents different combinations of race and sex, so that there's a different color line for white female at the top, Black female, white male, and then Black male at the bottom. And most striking is much lower life expectancy for Black male compared to white female at every time point. So in this table on the right, I include the values for life expectancy in the year 2017 based on race, Hispanic origin, and sex. So whereas the life expectancy for white and males is 81.2 years and 76.4 years respectively, the life expectancy for Black females and males, which is much lower at 78.5 and 71.9 years of age respectively. And so that means that for Black, estimated to live 0.5 years less than white men and 9.3 years less than white women, which is pretty staggering. So the reasons for these disparities are multifactorial, include the effects of social determinants of health, which is defined by the World Health Organization as the conditions in which people are born, grow, work, live, and age. and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So to better appreciate the impact of social determinants of health at the individual level, I turn your attention to this framework that was developed by the World Health Organization. So I know that this is a busy figure, so I'm going to highlight the key points of this framework, which shows that the socioeconomic political context in which a person lives can lead to unequal distribution of material and financial resources that shapes a person's socioeconomic position. And these socioeconomic positions then influence things such as working conditions and food availability that reflects individual social status. And based on an individual's social status, these individuals experience differences in health outcomes. So for example, a child who attends a public school with limited resources, where there is a constant turnover of teachers and classroom sizes are upwards of 40, may not receive the same quality of education as a child who attends a private school that has access to a wealth of resources, and each student receive more individualized attention in a classroom size of, say, 10. So these early educational experiences may influence their employment opportunities later in life, and these career choices and subsequent income then contributes to their living and working conditions, which subsequently affects their risk for certain health conditions, such as obesity and asthma. So to give you some more concrete data on the impact of social determinants of health on health outcomes, I want to turn your attention to some powerful images of New York City. So this figure here illustrates the percentage of people of color by zip codes in New York City, ranging from 4.6% to 98.2%. The darker purple represents a greater percentage of people of color in that zip code. And as you can see, overall, there's a higher percentage of people of color living in areas of Brooklyn and Queens and the Bronx as compared to Manhattan. The figure on the right in green illustrates the life expectancy at birth by zip code in New York City. So the very light green color represents the highest life expectancy, ranging from 84.4 years to 85.9 years of age. And the very dark green color represents the lowest life expectancy in this figure, ranging from 75.1 to 79 years of age. And what's most striking to me when you look at these two images side by side is that many of the areas with the lowest life expectancy also have the highest percentage of people of color, such as in the Bronx and areas of Brooklyn. And so you may look at the image on the right and see that the data is from 2006 to 2015 and think, well, this data is at least 5 years old and things should have improved by now. But it doesn't seem to be the case, especially when we look at the more recent example from April 2020 of the number of positive COVID-19 cases by zip code in New York City, which was the epicenter of the current coronavirus pandemic. So the virus affected low-income communities of color at a staggering rate, with Black and Latinos New Yorkers dying of COVID at twice the rate of white residents. So the image on the right in the shades of orange illustrates the percent of the population in each zip code who tested positive for coronavirus early in the pandemic. The very light yellow color represents the lowest percentage of positive cases, and the very dark red represents the highest percentage of positive cases. And if you look at the Bronx particularly, where I've circled in both images, on the right in blue and on the left in yellow, you can see that many of the areas with the highest percentage of positive COVID-19 cases also have the highest percentage of people of color living in that zip code. So while many of us are familiar with the disparities of patient populations affected by COVID-19, the racial disparities of thyroid cancer care are less well known. So studies have demonstrated differences in outcomes and experiences of racial and ethnic minorities in many aspects of thyroid cancer care, spanning from the time of diagnosis to the period of surveillance for recurrent disease. So the reasons that such disparities exist are multifactorial and include systemic barriers as well as patient and physician factors. So in one study of more than 25,000 patients with thyroid cancer, the authors found that there was a higher percentage of Black, Hispanic, and Asian Pacific Islander patients who presented metastatic disease compared to white patients at the time of diagnosis. Here, I list some factors that potentially contribute to these observed disparities in diagnosis of thyroid cancer. So first, the method of thyroid cancer diagnosis is important. So for example, it is important to know, and there's a difference in terms of whether the thyroid cancer was diagnosed after a thyroid nodule was felt by the patient, him or herself, or a physician on the physical exam, as opposed to whether the thyroid nodule was incidentally found on an imaging study, such as that of a CAT scan or an ultrasound. So in a different study of more than 2,500 patients with thyroid cancer, the authors found that compared to patients with larger tumor size of greater than 1 centimeters, those patients with smaller tumors of less than or equal to 1 centimeters were more likely to report that their thyroid nodule was initially detected with an ultrasound of the thyroid. Second, disparities may be related to differences in use of a thyroid ultrasound in different racial and ethnic populations. And third, it may be influenced by where patients actually go for their medical care, specifically thyroid cancer care. So this is a table from a study of 473 patients with thyroid cancer after thyroid surgery in 2 adjacent hospitals that were a couple of blocks away from each other in New York City. It shows that private university hospital patients were more likely to have thyroid cancer detected by an imaging test and have smaller tumor size compared to public hospital patients. The thing to note, though, is that the demographics of the patients who were treated at these 2 hospitals were very different. So while the private hospital group was composed of 90% white patients, the public hospital groups was composed of only 4% white patients, with the remaining consisting of 10% Black, 30% Hispanic, and 56% Asian patients. So in terms of surgical treatment, studies have consistently shown that surgeon volume is important in terms of patient outcomes. So in a study of 658 surgeons who performed thyroid procedures on a total of 5,800 patients in a hospital setting, the surgeons were categorized according to their total volume of thyroidectomies during that 6-year study period, such that Group A in the figure that you see here included those surgeons who performed 1 to 9 thyroidectomies during the study period. Group B included those surgeons who performed 10 to 29 cases. Group C included those surgeons who performed 30 to 100 cases. And Group D included those surgeons who performed more than 100 thyroidectomies during the 6-year study period. And what the authors found in this study was that the highest volume surgeons, or those in Group D, who performed more than 100 cases in the 6-year study period, had the shortest length of stay and lowest complication rates compared to the other 3 groups. So this figure is from a different study of more than 16,000 patients who underwent thyroid surgeries. The x-axis is divided into groups by surgeon volume, ranging from the lowest volume surgeon in the study, who performed 1 to 9 cases per year of thyroidectomy, and the highest volume surgeon who performed more than 100 thyroidectomies per year on the far right. So the different bars represent different patient populations by race, with the white bar representing white patients, the black bars representing Black patients in the study, the checkered bars representing Hispanic patients, and the bars with the diagonal lines representing patients of other race. And so for the purpose of emphasizing the study findings, I placed a dotted line that's red at the 50% mark. So if you look at the bars for Black and Hispanic patients, especially on the far left, you can see that more than 50% had thyroid surgery performed by the lowest volume surgeon. And then if you turn your attention to the group at the far right of surgeons, where I have put a red box, for the surgeons who perform more than 100 cases, you can see that while the percentages are relatively low compared to the other groups, there was a greater proportion of white patients who were treated by the highest volume surgeon compared to the other racial and ethnic groups. So here I list some factors that may potentially have contributed to these observed disparities. First, it may be influenced by where patients go for their medical care, as I have previously discussed. And the decision of where patients go for their thyroid cancer care is not made in a vacuum, but influenced by socioeconomic factors, such as the type of health insurance that they have. With the trend of patients becoming financially responsible for increasing healthcare costs, obtaining medical treatment for thyroid cancer can become cost prohibitive. So oftentimes, patients' health insurance will dictate which hospitals and which surgeons they have access to for their thyroid cancer care. Second, where a patient lives also influences their access to care. Many patients who live outside metropolitan areas, especially those in rural areas, may face barriers in accessing the relatively few number of high-volume surgeons in the US, since many of these surgeons practice in metropolitan settings or at academic referral centers. So in a study of more than 100,000 patients with papillary thyroid cancer who underwent thyroid surgery, the study authors looked at differences in demographics, treatment, and outcome for those patients who traveled to an academic center for their care compared to those who did not travel for their thyroid cancer care. And so what I have here on the slide is an abbreviated version of the table that they presented. So first, the authors found that significant improvements in number of quality of care metrics for patients from either metropolitan or from urban and rural counties who travel for their care. And second, while guidelines from the American Thyroid Association and the National Comprehensive Cancer Network were followed for the vast majority of patients, these guidelines were much more likely to be followed for patients who traveled for their care. So furthermore, racial disparities exist in terms of radioactive iodine therapy for thyroid cancer. So this figure is from a study of more than 280,000 patients with thyroid cancer. The x-axis is year of thyroid cancer diagnosis from 1998 to 2012, and the y-axis is a proportion of radioactive iodine under treatment, or those patients who did not receive radioactive iodine when it would have been appropriate based on the guidelines at the time. So for each of the curves represents a data for different race and ethnicity. And for the purpose of comparison, I drew over the line for non-Hispanic white patients in red. And so the authors found that fewer patients were undertreated with radioactive iodine in 2012 compared to that in 1998. And you can see in the figure that there's an overall trend downwards over time. However, in this same study, Black, Hispanic, and Asian patients were found to have a higher likelihood of undertreatment with radioactive iodine therapy compared to their white counterparts. So the reasons for such disparities are again multifactorial and include factors mentioned previously that influence where patients go for their thyroid cancer care. In a study that examined more than 189,000 patients with thyroid cancer treated at 981 different hospitals between 1990 and 2008, the authors found that there was wide between hospital variations in radioactive iodine use, with only 21% of this variation accounted for by patient and tumor characteristics, and much of the variance attributed to hospital characteristics. And so the study results seem to suggest that disease severity is not the only determinant of radioactive iodine use. In another study, in which 560 thyroid surgeons affiliated with 368 different hospitals were surveyed, the authors found that greater hospital-level use of radioactive iodine for stage 1 thyroid cancer specifically was associated with the following factors: fewer surgeon years of experience, general surgery specialty as compared to otolaryngology, and surgeons' tendency to perform more extensive thyroid resection. So even after the initial treatment of thyroid cancer, patients' race and ethnicity continues to influence their thyroid cancer care experience. So among low-risk thyroid cancer patients who have a favorable prognosis based on tumor characteristics, one study demonstrated that cancer-related worry is common in disease-free thyroid cancer survivors, even at 2 to 4 years following their diagnosis. So as you can see on the left side of the figure, 41% of the surveyed patients reported worry about death. And on the far right of the figure, 63% reported worry about recurrence of thyroid cancer. And the percentages of those who reported worry about harm from treatments, worry about change in quality of life, and worry about their family being at risk for thyroid cancer falls between 41 to 63%. In this study, the authors also found that cancer-related worry, including worry about death and worry about harm from treatment, was associated with being Hispanic or being Asian compared to being white. Furthermore, in a study of patients with low-risk thyroid cancer, we found that Hispanic ethnicity was associated with overestimating the risk of thyroid cancer recurrence. So the reasons for such disparities are again multifactorial, and they include both patient and physician factors. And so while the list here is not comprehensive, I illustrate some of those factors, what some of those factors may be. So patients' factors include patients' understanding and perception of thyroid cancer, their degree of health literacy, and their degree of trust of the medical system and of their physician. Physician factors include conscious and unconscious biases, degree of cultural competency, and their experience in and knowledge of treating thyroid cancer. The communication styles of both physician and patient is another important factor that influences patients' experience of their thyroid cancer care. So by now, I hope that I've impressed upon you the influence that race and ethnicity may have on many aspects of thyroid cancer care. And this leads us to the question of what can be done to move towards health equity in thyroid cancer care. And it's important to note that such racial disparities do not exist because of any one specific factor. As I presented thus far in this talk, it's the combination of many factors that contribute to the existing disparities in thyroid cancer care. So as such, the solutions need to take an ecological approach to achieving health equity for all patients. And in the next few slides, I list some strategies for improvement at the level of the individual, the institution, and in the sphere of public policy. So at the level of the individual, it is important to acknowledge and address any barriers that limit patients' access to resources. For example, if patients do not speak English, it is important to have an in-person or at least remote language interpreter available so that patients are able to understand the information being communicated by the healthcare team and able to have all their questions and concerns addressed. Similarly, it is important that as physicians, we're able to provide patients, if they would like, with educational resources, whether that be in the form of informational handouts or online websites that communicates information about thyroid cancer care in the appropriate reading level and in the patient's preferred language. And the American Thyroid Association and ThyCa does a great job in terms of providing information available in other languages other than English, as you can see with some of these screenshots from their websites. So being able to communicate effectively also contributes to shared decision-making, which is an important part of the thyroid cancer management, especially in regards to radioactive iodine therapy. So furthermore, due to the substantial cost of thyroid cancer care in the United States, it would be beneficial if financial counselors were available to meet with interested patients to discuss issues such as copays, insurance coverage of thyroid surgeries or radioactive iodine therapy, management of debt related to thyroid cancer treatment, and resources to help with payments of their medical bills. For patients with advanced thyroid cancer that is unresponsive to standard therapy, discussion with all patients about enrollment in clinical trials, if available at the institution, and regardless of whether or not physicians think that patients would be interested in the clinical trial is important. Additionally, given the time commitment required of patients enrolled in clinical trials and the frequent need to travel to and from the hospital, reimbursement for traveling and consolidations of study visits would decrease the financial burden for patients from lower socioeconomic status groups and those who are in jobs with less flexibility for time off from work. In terms of strategies to address physician factors, since a surgeon's volume of thyroidectomies influences patients' outcome, it would be beneficial to create opportunities for low volume surgeons to perform more thyroidectomies in order to improve their skill sets, such as under the direct supervision of a high volume surgeon at a nearby academic center, for example. Additionally, it's imperative that members of the healthcare team recognize and address any biases that they may have so that they could provide the same high quality medical care to all of their patients, regardless of race or socioeconomic status. At the level of the institution or healthcare system, the goal of decreasing racial disparities in thyroid cancer care needs to be made a priority by allocating time and resources to better understand the needs of the community that it is serving and to invest time and effort into designing interventions that aim to decrease barriers to access of resources for all patients. So for example, due to the distance needed to travel for an office visit or due to an inflexible work schedule for patients, It may be helpful for patients if hospitals offer the option of virtual visits by video or telephone, or office visits with a healthcare team outside of traditional business hours. On the other hand, with the recent move towards telemedicine by many institutions during the current coronavirus pandemic, we need to make sure that we're not ignoring those patients who do not have access to the internet or do not feel comfortable with telemedicine. The figure at the bottom illustrates the percent of Latino adults in the United States who reported using the internet in 2015. So while internet use is greater than 90% for Hispanics younger than 50 years old, it drops to 67% among those between 50 and 64 years old, and is only 42% for those aged 65 and greater and older. So as described under strategies for improvement at the individual level, increasing access to language interpreters and financial counselors will help narrow the gap between care received by racial and ethnic minorities. But these resources are only available to patients if the institution invests money in such services. And furthermore, for healthcare teams in more rural locations or who are less comfortable managing thyroid cancer, it may be helpful for both physician and their patients if there was a system in place to provide and exist for inter-institutional collaboration. So at the level of public policy, change is more challenging to achieve, but when it is accomplished, it has far-reaching effects. With the upcoming election less than 2 weeks away, one of the more important policies on everyone's mind is the Affordable Care Act. So in the United States, health insurance significantly influences patients' access to and utilization of healthcare services, including physician office visits and imaging studies. And many studies have demonstrated that health insurance status has a significant impact on the care that patients receive for their thyroid cancer. Furthermore, patients who are diagnosed with thyroid cancer at a young age may find it difficult to obtain health insurance at a later time, since a thyroid cancer diagnosis is then considered a pre-existing condition. So this figure on the slide illustrates the rates of non-elderly adult people in the United States who were uninsured from 2010 to 2018 by race and ethnicity. And you can see that overall, the uninsured rates decreased in the 8 years since the Affordable Care Act was signed into law. But there is a notable difference. It's notable that the uninsured rates for American Indians or Alaska Natives, or what is written as AIAN in this figure, and Hispanics are much higher compared to whites, where I have highlighted with the red arrows. So for some patients from racial and ethnic minorities, especially those whose first language is not English, it may not be enough to offer health insurance options in the marketplace. They may need assistance in completing the enrollment application and or prefer to talk to someone in person about the different health insurance options as opposed to reading about it on the internet online. Additionally, increasing funding for thyroid cancer research and for disparities research will help to decrease the existing differences in thyroid cancer care due to patients' race. And in terms of thyroid cancer disparities research, I've included on this figure some strategies to improve the breadth and depth of the data. So first, while large administrative databases that are used in many studies they could be revised to include additional patient information, such as the method of thyroid cancer diagnosis, access of patients to public transportation, proximity to a tertiary care medical center, and more classification options for race and ethnicity. Second, the utilization of surveys and patient interviews, in addition to information gathered from these administrative databases, will allow for patients' voices of their experience with thyroid cancer to be heard. And last but not least, collaboration with physicians who work in community practices or who belong to the racial and ethnic minority groups in the community may be meaningful because patients may choose physicians of the same race or ethnicity. And it's also important for these physicians' voices to be heard as well. So while there are still many unanswered questions about what other factors are contributing to racial disparities in thyroid cancer care and how best to address such disparities in order to achieve health equity for all patients, I hope that through this talk, I've demonstrated to you with the data presented that it's an important issue that needs more attention, and that you will continue to have this conversation with your colleagues, friends, and family beyond this conference. So to conclude, I would like to thank the individuals of the Thyroid Cancer Health Services Research Team at the University of Michigan who I work with. And this is a phenomenal group of individuals and researchers who are dedicated to improving patient care through their research. So I thank you for your time and for listening to this talk. And so I'll take any questions that you may have.
Thank you so much, Dr. Chen. Really appreciate your incredible presentation, and the data is startling. Yeah, I've been in those shoes myself, so I appreciate you sharing that. And I believe you can see. Can you see the questions as they're coming in?
Yes, I can see the question.
Okay,
So this is a question from Helga. The question states, given that there is racial disparities in medical treatment across all conditions, is there anything unique about thyroid cancer than something like diabetes or other cancers such as breast cancer? So I think the thing that is unique about racial disparities in thyroid cancer compared to some of the other conditions is a couple of things. So as I've shown in the beginning, the incidence or the number of new cases of thyroid cancer in the United States over the last couple of decades, they've increased astronomically. And so what that means is that there's a significant number of patients who were diagnosed with thyroid cancer. And for thyroid cancer, about 75% of those patients who are affected are women. And so in terms of our understanding of racial disparities in thyroid cancer compared to some other studies, I think the big thing is that there's not a lot of studies on that. So while there are racial disparities across many medical issues and other cancer types, I think the thing that is important is that why these racial disparities exist may be different. So the treatment of diabetes, for example, compared to the treatment of like breast cancer, compared to the treatment of thyroid cancer, there's something unique in each of those diseases. So for thyroid cancer specifically, there's the way that it was diagnosed, the initial surgery, sometimes radioactive iodine for those patients who it is appropriate for. And then there's usually this long period of surveillance. And while breast cancer may have a long period of surveillance, it's a different type of surveillance and there's different psychosocial impact on the patients. And so I would say that's a unique thing. So even though there's racial disparities in many things, I think the reason why those racial disparities exist and how we address them is pretty unique to the disease in and of itself. Oh, okay. So Helga asked another question. So let me read this. So the question is, has anyone looked into the hidden costs of thyroid cancer care, such as additional dental costs following radioactive iodine complications? Or I personally spent twice as much on food when I was on LID. I'm not quite sure what that is. But for patients with a limited food budget or relies on food stamps, LID would be very difficult to achieve. From my review of the literature on thyroid cancer, I don't know of any studies thus far that have looked at the hidden costs of thyroid cancer, specifically dental costs, but there is an increasing literature in the thyroid cancer literature that looks at what we call financial hardship or financial toxicity compared, within patients with thyroid cancer themselves, but also compared to other cancers. And so, for example, there was a study a couple of years back that looked at the rates of bankruptcy of those patients who filed for bankruptcy among patients with different types of cancer. And interestingly, what they found was that patients with thyroid cancer had a higher likelihood of filing for bankruptcy compared to, let's say, breast cancer or colon cancer. So there is some increasing data about the financial hardships and finances that affect patients with thyroid cancer. And I'm thinking of another study that may be important and relevant as well. So there was a recent study that we published that looked at Hispanic patients, particularly Hispanic women with thyroid cancer. So I'm just trying to make sure that it was a published study so that I could discuss the results. And so what we looked at was Hispanic women who had thyroid cancer and their report of financial hardship a couple of years after their diagnosis. And what we found was that their level of acculturation impacted their report of financial hardship, such that for women who had lower acculturation, regardless of their age, whether they were younger or older in the age group, in the study group, they reported that they had financial hardship, which was very unique. Just going to stop sharing my screen.
Okay. Thank you so much, Dr. Chen. I appreciate
No
you
problem.
taking the time to answer these questions.
I think
Do you
there's
have another one there?
Yes.
Or comment?
So Bridget, the comment says, I have a comment rather than a question. I'm a nurse navigator for a new thyroid cancer / RAI program, and we've definitely seen all of these disparities highlighted in our population so far. My job as a navigator is to help alleviate these barriers, but I know many people don't get that support. This work is so important, and I'm so grateful for your research and insights. Well, I thank you, Bridget, for your hard work as well, because the studies have shown thus far that having a nurse navigator or a patient navigator in terms of access for patients with thyroid cancer does have a significant impact on their experience, as well as the financial hardships that they have. So thank you for that. And then Amy made a question that says, did they look at the effect if someone was on Medicare or Medicaid in regards to age and race as well? So my level of care has gone down since I became disabled, and I am on Medicare. So there are many studies that have looked at the importance of finances as well as outcomes in terms of thyroid cancer, and looks at the impact of age, race and ethnicity, sometimes gender, as well as the type of health insurance status. I haven't presented that data here specifically because I was asked to present on racial disparities, so that was the focus, but there is studies out there. And oftentimes what happens is that there will be what we call multivariable analysis, in which you have all these factors and you try to account for those other factors and see what is important in terms of influencing the outcomes. Dolphin, the question says, in regards of follow-up after diagnosis and treatment, is there any significant difference of recurrence or death rate from ThyCa among ethnicities? I'm not sure I quite understand the question, but it sounds like the question is there a difference among ThyCa members based on their race or ethnicity? And if there is a difference in terms of the recurrence and death rate. There's not a study that I'm familiar with specifically looking at the cohort of ThyCa members. So
I think just maybe those with thyroid cancer. I'm not sure he's saying that it's ThyCa members, but just among ethnicities as far as recurrence or death rate. I think that was in one of your slides, this regards to the I thought I saw that there with the recurrence rate.
Oh, so there was a comment I had mentioned in which we looked at, it was specifically among a group of low risk thyroid cancer patients who, based on the tumor characteristics, had estimated based on the guidelines, recurrence risks of less than or equal to 5%. And so when we asked or when we surveyed those patients about their risks, their perceived risk of thyroid cancer recurrence and or mortality in about 10 years, we found that being Hispanic was associated with overestimating their perceived risk of thyroid cancer recurrence. So I hope that answers the question. And then Crystal, the question is there data on how a patient is treated during the process of preparation for surgery and what life will look like after surgery? Hence, what information is told to them and what resources are available? That's a good question. So when I reviewed the literature, there are some studies out there that have looked at the impact, especially from a surgical in the surgical environment of those patients who meet with the surgeon before their surgery and were surveyed about what their perception was, what information that they received, and what was most important to them, as well as what information they wish they would have received. And so the data in general, based on a lot of the information needs literature in thyroid cancer, is that there's still a lot of information that patients would like, especially in the surveillance stage. So after the initial surgery and after radioactive iodine, if that's recommended, that patients are still trying hard to find on the internet, or especially from their physicians, whether that be their endocrinologist, their primary care physician, or surgeons. So there is still a huge, I would say, there's still a lot of information that patient wants, but they don't have access to, or they want and they weren't given during an appointment. There's also studies looking at the communication. So that's part of the shared decision-making between physicians and patients. And so there are literature out there. There's not a ton, but it's starting to be, done more. So that's good, I would say. I don't see any other questions.
Thank you again for answering all these questions. And I appreciate that. I know we're, as moderator, and I got kind of swapped with our other moderator. So I'm a little new to this. So thank you everyone for being your patient with us once we got started.
And then there's a question by Amy that states, has there been a study like this looking at BMI and level of care? Because doctors misdiagnosed my hypothyroidism for over 30 years because they thought I was just fat. I ended up with thyroid cancer. The thyroid hormone treatment for my hypothyroidism would have prevented, the thyroid hormone treatment for my hypothyroidism would have prevented my cancer. We're able to prevent cancer for both my mother and daughter, as their nodules stop growing once on thyroid hormone treatment. My grandmother and her identical twin also had thyroid cancer like myself. I'm sorry for that experience, Amy. There has been has there been BMI and level of care? So there's not a study that I know of that looked specifically at BMI and level of care. And I don't want to comment on an individual case, just given that there's a lot of factors involved. But there's not a study, to answer your question, that I know of looking at this relationship. And I would say that some of the data that I presented, I included on the lower right-hand corner, the reference for it. So it should be easier for you, everyone, to pull it up if you're interested in looking at the data some more.
Okay, good job. Thank you.
Thank you.
I think there's some questions. I'll let you go ahead.
I think more comments.
So Nicole's comment states, my doctor said I just had fibromyalgia for years and I ended up with metastatic thyroid cancer. If they would have listened to me, I wouldn't be in the shape that I am. I'm sorry for your experience as well, Nicole. Wow.
Yeah, I think it's
Yeah.
I hear this as a facilitator commonly, that women and a lot of minorities get ignored with their symptoms. Oh, you're tired because you have a kid, or, I was told that repeatedly. So
I think, sorry.
No, go ahead.
And I think that's why it's important, especially given that thyroid cancer affects so many women, and even in Hispanic women specifically being the second most common cancer, based on the statistics, that it's important to have funding to look at disparities, especially based on race and gender in thyroid cancer. And so just kind of swing back to the first question of what's unique about it. I think, even though breast cancer, for example, impacts women primarily compared to men, thyroid cancer and breast cancer, the nuances of them is very different. And so it's not necessarily the case that you can extrapolate findings from the breast cancer literature to the thyroid cancer literature. And so there may be unique factors, I would say, especially in that initial conversation with the surgeon or endocrinologist at the time of diagnosis, that influences patients' understanding of their thyroid cancer, how they communicate that to their families, for example. And also because many people, especially those with low risk thyroid cancer, or thyroid cancer like microcarcinomas, they live for such a long time period. You carry this thyroid cancer diagnosis with you. And so the impact of how it was presented initially is very important, but also like your worry about this thyroid cancer recurring or whether it will impact your family is very important and affects your quality of life in many ways. And so I would say that's a huge reason why disparities in thyroid cancer is so important, and why many patients, I would say, as much as we're able to achieve health equity in thyroid cancer care, that would be the goal. And so that's why I think this work is so important. I'm sorry, let me go back to some questions. So Amy's question, has there been any research on how the race and ethnicity of surgeons affect the kind of disparities you've discussed? There's not, I'm thinking. There may be some studies on this, but none that I am familiar with right now. And so I would say a lot of the literature that I've seen in terms of the surgeon, a lot of it is focused on the surgeon experience, specifically their volume of thyroidectomies per year over a study period, and how that impacts patient outcomes. And a lot of that, I think the focus is because depending on where you live in America, and specifically what your health insurance is, because right now that's a lot of talk in the news about health insurance or access to health insurance, that influences significantly what surgeon performs your surgery. And a major part of that, I would say, is that as patients, not a lot of us have, we don't necessarily have a say in which surgeon is in our insurance plan. And we don't necessarily know the information about what the patient volume is, or like the volume of thyroidectomy is when we go to the surgeon. So while many patients may ask a question of how many surgeries or thyroid surgeries have you performed in the last year, in the context of whether that is low volume versus high volume, is not necessarily transparent. And I think that's a lot of where the surgeon information comes in for this research. And then Jennifer made, I think this is a comment. So unfortunately, I was often dismissed for my symptoms after surgery. My doctor never listened to me, and it was the nurse that actually recognized my issue. Well, I'm glad that happened. That at least the nurse was able to recognize your issues and address that. I have since changed doctors, and she listens to me. It wasn't until I became a facilitator that I realized my symptoms were the same as other people. Thank you for sharing that. And I'm sorry for that experience of being misdiagnosed or a misdiagnosis in the beginning. I would say that there is some research, especially thinking the breast cancer literature, that looks at communication types, as well as communication preferences between patients and physicians, and how that impacts the interaction. So I think that's also important, especially in terms of thyroid cancer care, because like I said, the initial encounter, or at least in the beginning of how the thyroid cancer is diagnosed, is very important. And it's important also from a standpoint of based on gender or based on race or based on certain types of community and like educational experiences, for example, is there a particular communication style or decision-making preference of patients versus providers? So that's an important topic to look at as well. I think the rest are coming. Thank you for listening again. I think we have a couple more minutes if there's any more questions.
Looks like it's mostly comments there. And
oh, sorry, I didn't see that last one.
And yeah, it's okay. I think they're mostly just comments. And then Dr. Chen, what can we do as patients to kind of help bridge this gap that's been occurring and continues to occur? Are there steps that we can take to help others who are in this kind of situation? I know that you mentioned there were lots of materials that are translated into other languages. I've actually gone to some appointments with some other patients just to kind of be their note taker, and to help them with that. But are there some other thoughts that you might have that we can?
I mean, I think especially through ThyCa, this is such a great organization, especially for community, for patients with thyroid cancer. And I think a lot of it is at this time, there's the information gathering part of it, in which we try to understand what exactly is the existing racial disparities. And then the next step is what are those factors that are contributing to it? And then not the final, but the next step, which hopefully will lead to change, is these implementation at different levels of the individual, the institution, as well as public policy. And so I think continually there's research in every aspect of these strategies for improvement and to achieve health equity for all patients. And so as a individual in our society, I think any part of those, I guess, your question is specifically what you can do. And I think before I listed a couple of different strategies, and I think if there's any one that appeals to you, that those are things to work towards. So for example, if you're someone who enjoys advocacy or feels comfortable advocating for research funding, that would be something to do. If you're someone who enjoys talking to other people and advocating on behalf of this topic, I think that's something to do as well, because racial disparities in thyroid cancer care, some people may not know about it. So while there's a lot of there's literature on it, your friends or your family members this may not be a topic that you talk about. And I think to increase that awareness is as important as if, advocating on behalf of all these patients and this organization for more funding. And the other thing I would say is increasing awareness about the factors that contribute to health disparities. So I would say, for example, health insurance has a significant impact in terms of the type of care that you can receive. And so I think, even though health insurance is very important, I'm not aware so far, but the audience and you may be aware of, are there certain types of health insurance that there's a certain type of community may prefer? Is that a low deductible versus a high deductible health insurance, for example, or for patients in certain communities that are more likely to be uninsured? Is the issue because of their awareness of these health insurance plans on the market, as opposed to their perception of this is not something that I can afford because they don't understand certain aspects of it. So I would say increasing the awareness of these factors to try to decrease that gap was very important. But there's not a particular, list of things to do, because I think all of them are important. And the way that we address it, I think, is whichever you feel like resonates with you. I think that's the most important. And so for
This is
myself,
Angel.
yeah.
We have about 4 minutes, but we also
Okay.
have approximately 10 minutes that we can go over before they completely shut us down. I see there's a couple more questions.
Okay.
I just wanted to touch on something. I wasn't in, with a racial disparity group, but I could speak for most women that I too was misdiagnosed with fibromyalgia for many years. Even after my thyroid cancer surgery and after starting a hormone, synthetic T4 hormone replacement, was told that I had a mental issue, I had neurologic problems, I had depression, anxiety. It was everything except the fact that my body did not adequately convert the T4 hormone into T3. And it wasn't until I switched from synthetic T4 only to a desiccated thyroid, such as Armor, I don't use Armor, but such as Armor, that I had a lot of relief from that. But as Dr. Chen suggested, you have to advocate for yourself. Don't let any question go unanswered. Keep searching, keep trying. I know it's difficult with insurance and getting into the physicians, but don't let them tell you otherwise when you know that it's something physiological that needs to be looked into. You can demand the testing. You can ask for tests to be written into your progress patient report so that the doctors will then test you for what you need to be tested for. For many years we suffer, and it was told, we were told menopause, it was this, it was that, it was everything but the thyroid, because the levels looked good, the TSH looked good. And it really wasn't. It really wasn't at all when I looked back 10, 15, 20 years back through blood work. So I just want to make sure that people are aware of that there could be other avenues to go into as far as being heard and things to look for. It goes for men too. I see we have some men in our group and they've also suffered immensely, the same thing that we're suffering with. So, okay, go ahead. If you have about 5-7 minutes left.
And I just want to add a comment about that. So thank you for sharing your story as well. I think it's very informative as physicians also to hear patient stories, because a lot of our research is inspired by patient stories. So continue sharing them, in platforms such as this. I would say that an important part about thyroid cancer, most of you are familiar with it, but in terms of from the general audience standpoint, there are organizations and such as ThyCa and American Thyroid Association that do have patient education areas to learn about thyroid cancer and like the steps along the way. So those are important resources, I would say, as well. And let me see, there's a couple more. Lynn made the statement, my brother had papillary thyroid cancer, and 8 months after his diagnosis, I was diagnosed with the same type. Is there research on papillary/follicular that shows that it is familial or genetic? So I don't want to comment on a specific case, particularly without knowing more information, but there are guidelines about when it would be considered, like when the next steps would be genetic testing. And so those would be the American Thyroid Association guidelines. They do have guidelines for that. For in what situations would this be the next step, or what is the likelihood that a type of thyroid cancer has a genetic link as opposed to not a genetic factor from there. So there's information on that. And so I would refer you to the American Thyroid Association guidelines. And then Judy's comment or question states, a lot of thyroid cancers are found accidentally during other medical encounters. So health coverage is a factor in delayed diagnosis. What other aspect of race and class influence delayed diagnosis? So health factors is health coverage is a, okay. So I think so my understanding of the question is that the type of health insurance that you have influences at what point, at what point you're diagnosed with thyroid cancer. So specifically, if you have health insurance, you see a physician and they feel your neck and are able to feel a thyroid nodule, as opposed to if you don't have health insurance and you delay your care until that cancer gets much larger in size. So I think that's my understanding of what Judy's question is. And so to answer that question specifically about health insurance, I would say the difference between having health insurance and not having health insurance, or the type of health insurance, is important. And then Judy's other question is, are poor people and people of color less likely to be taken seriously? I think if they're asking if there's a study that looks at that particularly, I don't know of any off the top of my head. But I would say that there are, like I presented, like someone's race and ethnicity influences different aspects of the care that they receive. And so a lot of the research now, and I think what needs to happen is really understanding like what is it about someone's race or ethnicity that is associated with these outcomes. And so hopefully we'll have those answers soonish rather than later.
No, I agree. I think that's important to, hopefully they'll be looking into that as well. I think too, though, just to dovetail on the earlier question, was that I think it falls on us and these minority communities to also approach medical care as necessity, not a ignore it kind of thing, and to not be in that, because I know in the Indian community, there's a tendency of like, whatever the doctor says, you just do it, and if they say it's not a big deal, you just go, okay, it's not a big deal. And instead of questioning them, and when I started speaking up, some of them got turned off by that. It's like, hey, you're the younger, you're supposed to listen to what I say. So it's like, I think there's that flip side to it too, where we have to kind of say, again, what Angel was saying, advocating for ourselves. And it's speaking up and bringing people in if we need to as well. And I think we're close to out of time, but I think we might have another question there at the bottom.
We have time for another
Yeah.
question. Amy's question is, thank you for answering my earlier question. I think it's important for doctors to continue making the diversity of the pipeline into the profession a priority. While being treated for my blood cancer, I felt dismissed at the white male doctor I had been assigned. I pushed to be reassigned to a doctor of the same gender and race, and it was night and day. And so, I emphasize that the diversity in terms of patient population as well as the physicians and surgeons is important. And so that's why on one of my slides in terms of strategies for improvement in research is not only hearing in the literature the voices of patients, diverse patients with thyroid cancer, but also hearing the voices of physicians and healthcare practitioners who care for patients with thyroid cancer. Because, I think everyone has something important to say. And so it's important that we highlight and provide a platform for that information. So I think we're out of time now, but thank you so much for joining us on this talk. And I hope you enjoy the rest of the conference.